virtually. I did virtually yesterday, I think it was yesterday for you, 2 days ago for me, with some virtual remarks. And I just really appreciate the opportunity to be able to come in, and I wish that I could be with you in person, but I am, I'll call it stuck here in the legislature. We're in session right now, and so we can't leave the building. But I am really grateful to be here on the traditional territories of the Lekwungen speaking peoples, the Songhees and the Esquimalt First Nations, and a chance to connect with so many like-minded people. And I just appreciate your dedication to furthering the really incredible and important research that you do and are involved in and improving health outcomes for people. I myself have a background in science, having practiced as a professional biologist as the first part of my career. And although never deeply involved in research, and certainly not medical research, I do and always have believed that research really is the foundation of advancement and making change, and that change has to be grounded in sound research and in collaboration. And so events like what you are having right now, bringing together partners from across their health system, can be a real catalyst for putting that research into practice. And ultimately, this is about delivering better healthcare for people in our province. So speaking to a room full of people who do this work feels like the right place to be, to announce more formally that as the result of so much extensive research and collaboration and incredible work by so many people, that we are officially launching a new provincial framework for suicide risk reduction, and that this framework will provide improved clinical guidance for healthcare providers and organizations to help them better recognize and support people who are at risk for suicide, which in turn will help more people get the right care at the right time and ultimately save lives. And every single life that is lost to suicide is a profound tragedy, and it is a really heartbreaking reality that here in BC there are more than double the number of suicide deaths than there are of motor vehicle fatalities. And I find that to be a very sobering statistic. It really puts things into perspective and gives an incredible amount of resolve to act now to change this. So this new framework that's been developed with our colleagues at the Canadian Mental Health Association's BC division, I just cannot thank enough. This framework will help clinicians better identify people who are at risk for suicide and provide that guidance for improving care through a very personalized, person-centered, culturally safe approach, and being able to facilitate a more warm and empathetic care experience for patients, really laying groundwork for how we care for people moving forward, and really to better help people who need it most. And this is part of a much bigger picture within the province and the Ministry of Health and our efforts to build and expand the mental health and substance use system of care across the entire care continuum to really help people access the right supports no matter where they are on their journeys. And I certainly, over the last 5 or 6 months, have been just so grateful to meet so many incredible dedicated partners like CMH ABC, and I know that this is work that we're all doing to make a difference, and there's still a lot more to do. So we're going to continue, and we're going to continue to work hard in BC here to get more people the care that they need. It's encouraging, I think, for all of us that we're not alone. And again, I'm just so grateful that you're gathered together and that there's so many people like you who are doing the work that you do. So that's the extent of my remarks. I just want to say thank you to each and every one of you. Thank you to the event organizers for letting me pop in and do this. And I know you're going to have a successful and rewarding panel here, and I hope the rest of the conference is as well. So thank you so much.
All right. Thank you so much, Minister Osborne. I think as we talked about on Tuesday, this is really a significant step for British Columbia of really laying the foundation and the groundwork for, the continuum of care from prevention to crisis intervention, and that we're treating it with the same seriousness and understanding the precision of care that's required for assessment, diagnosis, and treatment intervention, whether it's physical health or mental health. So on behalf of UBC and researchers, and as the Director of Advocacy for the BC Psychological Association, I can tell you this is going to save lives, and we're so honored to be able to unveil this framework today and to share a little bit more about our one project, which was one of 5 that went into the development of the framework. So thank you again, Minister Osborne, and the endorsement. And I can say it's been amazing to partner with the ministry, and the lightning speed and the seriousness upon which you're taking mental and behavioral health is absolutely inspiring. So thank you very much. And with that, I'm going to actually move it over now to Maria, who actually gets to unveil officially the framework that you have been working for many years on. So over to you, Maria.
Wonderful. Thank you so much, Minister Osborne, for those wonderful remarks. And thank you, Leslie, for getting us started here. Next slide, please. So we're going to start, as Leslie's mentioned, I'm going to talk to you a little bit about this project and kind of where we got started and our exciting new framework that's being released officially today. Amy and Dr. Lutz, as well as Dr. Zaidoff, will then talk about kind of how this project has been operationalized in one of our healthcare systems, so through Interior Health Authority. Next slide, please. Thank you. Awesome. So yeah, so this project essentially, we got funding a couple years back now from the province of British Columbia, and have been really grateful for the ministry's commitment to kind of a system-wide transformation in how suicide risk and care are addressed and managed kind of across our province. And this initiative essentially had 2 components. The first was the development of this provincial suicide risk reduction framework for clinical care settings. And then the second counterpart that's happening kind of in conjunction with the development and now release of the framework was dedicated quality improvement work occurring in the 5 regional health authorities. And so this framework was really designed to promote a best practice approach in how people address and manage suicidal crises in the settings where folks are presenting for help. It's intended to foster consistency, so making sure that there's kind of a central best practice resource folks can rely on for clinical settings across the province. And then we're really grateful as well that this framework was actually developed broadly through a long iterative process with many, many wonderful partners that ultimately culminated in an endorsement of the framework by our province's provincial medical directors for mental health and substance use. Next slide, please. Awesome. So I'm sure I don't have to convince you folks of the importance of this work, given that you're here attending our talk today, but sometimes we do get questions about, why focus on healthcare as a setting for suicide prevention, or specifically within the context of this work, why emergency departments? And there's plenty of research that's done. There's 2 specific studies that we often quote, one out of Quebec, one out of Toronto at Sunnybrook Health Sciences, that cites that upwards of 50% of people who died by suicide presented to the emergency department within the year leading up to their death. So it really is a critical place people with thoughts of suicide are interfacing with the healthcare system. And particularly for EDs, we know that folks who have urgent need for care for their thoughts of suicide primarily get sent to the hospital at this stage through the emergency department. Next slide, please. So what you see here on the slide is kind of an infographic summarizing the framework that we've put together. The framework is a multiple page document, but this here I would say kind of summarizes the key points. We talked a lot about the importance of screening that's universal, standardized, and low threshold, moving into management, so criteria for what we would look for in the management of suicide as a presenting concern. Looking at specifically, we've got these boxes that kind of highlight more information about what a safety intervention looks like, and also the importance of transition and follow-up care. So I won't get too far into the details of this, but I'm so thrilled to announce that you'll be able to find this very soon publicly and utilize this in your work. Next slide, please. So what we're about to hear about here, and then I'll transfer things over to my wonderful colleague Amy with Interior Health. Like Leslie said, there's projects happening across the health region. So this one through Interior Health is one of 5, but I think you're in for a real treat here learning about the amazing research partnership between UBCO and Interior Health, with some really dedicated work on focusing on standardized screening in emergency departments across the Interior Health region. So I'll cut things there. I'll pass things over to my colleagues. And Amy, I think you're over to you.
Awesome. Thanks, Maria. Next slide, please, Lacey. Yeah. Interior Health has 29 emergency departments that we service in our region, varying from rural to tertiary sites, with the majority of our sites being rural. It's really important to understand these differences based on location and geography and the resources that are available in these communities. Next slide, please. Suicide screening is a required organizational practice in terms of accreditation standards within Interior Health. And this means that we really need to focus on this practice area. In 2022, with amazing support and funding from our Canadian Mental Health Association partner, Interior Health had the opportunity to work alongside UBCO and our research team to review suicide screening in the EDs across our region. This research was started after we had done a big education rollout as a result of the required organizational practice for accreditation, which surrounded the use of the Columbia Suicide Severity Rating Scale. And next slide, please. The Columbia Suicide Severity Rating Scale is a simplified screening tool that uses plain language questions that really anyone can ask. It's the gold standard in suicide screening and doesn't take long to complete. It's vital in care planning and reducing death by suicide. And in Interior Health, we updated the form to make it really simple to use and really make it easy to stratify risk. And over to you, Dr. Lutz.
Thanks, Amy. So I wanted to share with you briefly the 3 phases of the project, with one of them still ongoing. Phase 1 was an independent chart audit of patient chart data, where we flew over to 9 different EDs across the interior. Phase 2, a healthcare provider survey to physicians and nurses. And phase 3, patients with lived experience patient survey. So in summary, phase 1 was the independent chart audit. So currently in Canada, we use the CDIS complaint codes, the Canadian Emergency Department Information System, to identify currently what people are coming in for. And so we identified 5 different codes for either acute mental health crisis, substance use, or overdose for the reasons why people were brought into the ER. We then had the data pulled for every single different site, and we used a REDCap data survey system to enter the data. We had our teams of researchers fly around and drive to 9 different emergency departments, and where they had over 30% of random charts pulled by the health authorities randomly, that accumulated to 1,491 patient charts that were reviewed for this first phase. So here's the data in summary. In summary, 1/3 of presentations were for suicidal ideation. The other 2 were for behavior, for alcohol or for overdose. What was most notable was that less than 10% of the patients were completed that CRSSRS screener presenting with suicidal ideation. Now, why this is going back important, as Maria said, is that right, not only are 50% of people who are dying by suicide presenting to ERs, that 4-minute screener does actually predict risk across time. So right now, currently only 1 in 10 patients are receiving that screener that are presenting for mental health crisis. The other piece of data is that when you look at all those charts put together, the 1,491, that less than 3% of the total sample had the CSSRS completed as a screener. Now, we know people with alcohol overdose typically have sometimes other elements of mental health as a part of that, but that, again, that only accounted for 3% of the total population. Now, when we looked at, could this be accounted for by hospitalizations? When we looked at the secondary data, it could not be counted for that people didn't get these screeners completed because they were actually just admitted. So now let's move on to phase 2 of the data, the healthcare provider survey. We sent out, Amy actually sent out to all of the different providers a Qualtrics survey via an internal newsletter. We had almost 60 providers, 21% physicians, 80% nurses, who completed the survey. It took about 15 minutes. It was quantitative and qualitative, a mixed methods data collection method, in order for us to be able to have the rich analyses, quantitative data, but also thematic analysis. So while there's a lot of different data, we want to share with you the most important significant points from the physicians and the nurses. The providers indicated that 90% of them felt unfamiliar with the CSSRS at this time. And only 1/3 had reported that they'd received training to assess or manage suicidal ideations. Now, I want to be clear that's different than what they actually did receive, but the perception was that only 1/3 of them received that they received that training. And most notably, that only 5% of these providers felt completely competent in treating suicidal ideations as a part of their care in the ER. Now, I want to preface this data understanding we are on the heels of the COVID-19 pandemic, the burnout and the fatigue of the healthcare system. So I want to be very clear is that this was implemented, the new screening requirement was implemented at a time that I would say the system was starting to really, really show the signs of fatigue, and that you can implement something, but you also need the resources, the power, and the support to be able to have it implemented. But I think, again, it shows that Amy will talk about that they've done education trainings. It's just, but the providers didn't feel like they don't remember even receiving that training at the present time. So here's probably another piece that was very important. We did ask the providers how helpful, right, as a psychologist, we gave an example. How helpful do you think it would be if a psychologist would be part of the ED medical team? What we found is that 86% of the providers said that, in fact, this would be an incredibly helpful thing to have a psychologist who specializes in that as a part of the ED team. Now, I want to put this in the phase understanding of how many people are coming to the ER for their care daily for mental and behavioral health. Next slide, please. So I think that what was important is that if you use the CDIS complaint codes, that is currently how resources are given across the country for understanding what EDs are needing in terms of resource. Currently, the data shows nationally that 1 in 20 people are presenting to ERs or EDs for mental and behavioral health crisis. But the data from the providers told a very different story. They actually said that 7 in 20 patients are actually presenting in mental and behavioral health crisis, which will be in just a minute as Dr. Zioff will talk about how we're trying to get to the bottom of that. Again, using that front end presentation, something like someone presenting with troubled vision or chest pain could actually be in the end a mental health, right, diagnosis and treatment plan, but it's being missed kind of in that front end potentially with using the CDIS complaint only for that presentation. And then phase 3, which is currently ongoing, so we don't have any results, but Aiden is one of the students that sent over 2,000 text messages to individual patients following their visit to the ER for mental health reasons. And we had 46 responses so far from patients with lived experience. We did, again, both quantitative and qualitative analysis because we really want to understand, just like with the providers, the thematic analysis in addition to quantitative data, because we think it's so incredibly important. So with this, I want to move it over to our emergency medicine director, Dr. Zioff, to talk about kind of what this means moving forward.
Thank you very much, Leslie. Thank you to those who have spoken before me and for the work on the framework and the support from Honourable Minister Josie Osborne. That's the key. That's the foundation to really getting this work moving forward. And it's a collaborative work. As you've heard about some of the challenges that are facing our processes through this research, through the data that we've gleaned in collaboration with UBCO, it has given us insights on where we need to focus our work. So one of those places is on the education piece, really digging into supporting our frontline in being familiar with these tools and being able to know how to access the resources that they need to support patients, and building the tools, the clinical care guidelines and pathways, so that right from the front line, when the patient walks in the door, right through to the back end, that they have the tools and the support that they need to bring those patients to the right place to ensure that they have the appropriate follow-up or admission as required. I think another piece along with that too is just acknowledging that patients they come from all different places, and to really build into that training, that trauma-informed care and that cultural and safety piece, especially for our Indigenous patients as a part of this population. So those are some of the key pieces around education. Advocating for resources is another really important part. As you are all aware, ongoing resources are stretched in the healthcare system. And I love the question around bringing psychologists into the team of caregivers who are supporting these patients. And I think the question goes beyond that, and to say who else? You know, we can't keep asking the same people to do more work. We need to expand the team. We need to broaden our pool of resources, and particularly not only for our urban centers, but also really, you know, trying to bring equitable care to our rural communities. And what creative possibilities can we bring to those communities? And these are some of the strategies and the priorities that, as a clinical network, we're looking after regional care for the emergency patients across Interior Health. These are some of the strategies and the priorities that we focus on to really try and bring that quality and that equity of care for our patients, in this case, presenting with suicidality, or not presenting with that, but throughout the course of the visit being identified as having that concern. I think the other really important piece is the you know, the follow-up care, and really being able to identify those pathways of you know, of identifying where that patient goes next. And that's one of the biggest risk periods of time, is immediately after seeking care. If left hanging out in the community without the proper support and follow-up, that can be a really high-risk time. So ensuring that those resources are in place, working closely with our other colleagues in collaboration with our mental health and substance use teams within the region to really bring those pathways, not only for, again, for our bigger centers, but also for our rural centers, you know, tapping into virtual care, and also making linkages to primary care practitioners, who are going to be the foundation for these patients long term. Really bringing these pieces together, and is where we need to go to help support. And this is it's a big vision. It's gonna take time. These sorts of efforts and quality improvement pieces within the complex system of healthcare take time, and it takes collaboration. We need all of our partners at the table, and we have been just thrilled to work with UBCO and CMHA on this work, and we'll continue to sort of explore those avenues and how we can collaborate together to bring the best care to patients. As we move forward, it is really important that what we do gets measured, and that we identify and evaluate the opportunity for research and for fine-tuning those pieces, not only as a quality improvement process, but also being willing to innovate and say, this worked or this didn't work. So working closely with our colleagues such as Leslie, UBCO, and her team, and Aidan, to really help you know, identify robustly the benefits, the value, and the opportunities within those different pieces that we bring to the table. I think that is really important work moving forward. You can flip to the next slide. One of the pieces along this is identifying sort of the missed opportunities. You know, our CDIS complaint is the presentation of a patient as they come through the front door, and as my colleagues in medicine will identify, that's often not what comes out the back end. You know, it's what somebody may present with, and what kind of comes out through that period of vulnerability and that period of time interacting with the healthcare professionals. Really, the on the way out on the other side, the diagnosis, or being able to identify what the actual issues were on the table. That's the part that we are looking forward to exploring further. In one of our facilities at Royal Inland Hospital, we've been able to build a piece of the discharge diagnosis in a data set. So we're working hard with our analytics team to pull that information out so that we can compare what comes in and what comes out on the back end, and really identify truly where the resources need to be built into the system and what we might be missing, you know, in this data so far. So future work, that's one small piece of many opportunities to continue to collaborate together. So I'll pass it off to you again, Leslie.
Thanks, Aaron, so much. So we summarized 2.5 years of work in 14 minutes. So hopefully we've captured that, you know, I can't state this enough, is that we wouldn't be here today. Every time people said, you can't do all this, you can't fly OTRs and get this data, you can't, right, have all these teams, you can't text patients directly. But every time we brought these issues to Amy and to Lisa and to Aaron, every time there was a barrier, I can tell you absolutely, they got on the phone, they solved the problem. This was our 14th different iteration of our study and the pivots that we had to make. I can tell you that the partnerships, this were crucial. It was not us coming in to do research. It was not evaluating a group. It was not an agency, doing their frame. It was really, truly a partnership, and that every step that we communicated regularly and anytime changes were made, we did it as a team. So, and I'm just so grateful. And I know she's not on the panel, but Elisa, I have to give you a formal shout out there at IH. You've been amazing over these last 3 years. And it's just been every time we hit a bumper or hurdle, the answer by the IH team was, we can figure this out. We can do this. And every time I'd email Maria in a panic with needing something, it was, we can do that 5 minutes before our presentation. So incredibly solution focused. So we didn't focus on the problems, we focused on getting the solutions. Problem solving therapy is now a skill set our entire team loves and embraces, because it isn't if but when. That was really a mentality we had to have very early on going into this partnership. And navigating systems, understanding the REB systems with here at the university versus IH. And so understanding how do we navigate the systems of asking the right people to sit at the table really, really was critical. And having champions, I can say that Lisa and Amy and Aaron were incredible champions for this work every single time that even there was barriers put to them for issues. And Maria and Johnny Morris, the CEO of CMH ABC, I think, which is joining us as well. Incredible, incredible champions of having equitable access to effective mental health services has just been amazing. And also having shared values and objectives. The three of us, our three groups, absolutely share the same value, which is moving us forward towards patients getting the care that they need at the time that they need it, and that it's effective, and that we know it's effective, that it's being measured. But everybody knew that the risk of suicide in those first 7 or 10 days following, again, discharge from an ER, we saw that as a really big, risk point. And so already our team is talking about partnering. Aiden has been working hard, actually talking to groups in Ontario and seeing how they're doing automated calls as one research study as a way to even just reduce risk. And so, from the team at IH to CMHA to the researchers here and to the graduate students who are doing amazing things of helping navigate in real time, other groups that are doing this work, and how do we help move it forward very quickly. And in terms of that's evidence-based, but it's who that shares the same values and objectives and allows us to be much more efficient. And it's just been an absolute pleasure and an honor to work with everybody. And we now always, the thing is, what's next? What are we going to do next to improve and work on things? And I do have to give Interior Health a very big shout out in terms of their willingness to look at this and to publicly talk about this and show the data of where this is as a starting point. When over 20 years ago in the UK, when they started the program called Increasing Access to Psychological Therapies, they said, we can't treat it unless we know where we're at. And that was the brave step that the UK took over 20 years ago that has now resulted in significant transformation of their mental and behavioral health and their healthcare system. And so I feel like IH has really taken this leadership role in saying, we want to be the first ones to talk, to show and to look at this data and how do we get better. So that's really, I do want to give a shout out to, I know every health authority is working, but I've just been really grateful that IH allowed us to go in and independently look at this data as for all of us to be on the same page of where we go next. So with that, I want to turn it over. I think we're now going to do a Q&A from both people in the room and people that are online, because we do have 20 minutes left. I know the minister can't be with us anymore, but we are happy to share questions and answer what we can in terms of our project and, how we got here and where we're going.
Well, we can take questions in the chat. Lacey will help us out with that.
Yes, absolutely. Yeah, so absolutely. And I'll just have to repeat for the people online if they can't hear it, okay? But
yeah.
Yes.
Yes,
sure.
So my name is English, and I work in mental health and psychiatry. So it's interesting because I think there are so many connections between my work and your work about emergency departments. Actually, I did a study about what gets in, what gets out, just in different contexts. So I'll kind of chat about it. But my students and I are doing a project about emergency department and racialized youth, maybe not youth, but young adults, immigrants. So she's also seeing the fragmentation and the follow-up. She does it in Ontario. But I was wondering if you can speak based on the data from patient files, if you have observed any patterns about like kind of in terms of race and gender,
Yeah.
who was getting those surveys and
That's a great question. The running joke is that we always reference Laverne. She's a researcher that does really fantastic work. She did a study recently in BC looking at people visiting EDs for mental health reasons, mental health and substance use reasons. And the data is pretty clear that those racialized groups, are presenting to EDs. I can definitely provide some links, but to speak to your point, there are also, immigrant youth that often have their first interaction with the healthcare system in an ED, often for mental health reasons. So I definitely hear what you're saying. Hopefully online everyone could hear, the question that was posed. Yeah, thumbs up. Okay, wonderful. But we're definitely taking that into account with the research we're doing. And that was a big component of the surveys as well. So, we had the privilege to work with Interior Health to directly reach out to those with lived experience and ask what went well, what didn't go well. We had those qualitative bits too, to kind of for people to share their story, how they could see things improving down the road. So it's a huge, I think, component of the work we're doing, and I definitely hear what you're saying. I hope that helps. Yeah.
Well, so let me just clarify, in phase one of the study, when we did the independent chart audit, that the biggest missing piece of data was demographic information.
Yeah.
So that's part one. It's also not required to have very specific, there's not requirements currently in the EMR to have, backgrounds, cultural, racial backgrounds and different things as a requirement for the EMR. And so I think that is something that for me was a huge glaring hole already when I started looking at the data. But, again, you have busy healthcare workers expecting them to re-enter that data every time. I think wondering whether if there's some way to tie it to the PHN or some other metric, like a way to help it be in the system, right? Because what we do know is that when you're not tracking it, it's even worse, right? So again, I go back to just understanding is the base level of where are we at, right? You saw the data for the CSSRS completion, that you look at the most missing piece of data, and again, not a requirement, but the missing information was demographics. So that is an area that I thought was significantly an opportunity for discussion, and how, again, as we're, everybody in this team has the absolute laser focus of, providing this care, but also to significantly reduce the health disparities, which we already know are in very plain sight. And that, so we're, wondering how can the EMR, start to be a thing that's helping, track that information, but having that information as a way to also more seriously identify what is going on or what isn't going on in the ERs.
So to give more specifics, the only consistent variables we had in the patient charts were age and sex assigned at birth. And so I guess the component that, we're hoping to recommend is linking the PHN with that data to probably the patient charts, so that that's easily accessible. So yeah.
But no other thing, and there was a significant amount of missingness, right? So in that, but no other information, right? Even in the EMR as a potential to collect. Yeah.
There's interesting work about how women sometimes claims about suicide violation are being dismissed as kind of overreaction. So I think this would be interesting to see whether there is a pattern correlation. Who was getting this kind of story and like not getting because of the gender.
It's a great.
Yeah, Amy or Aaron, do you or Maria, do you guys have anything to add there?
You know, Leslie, we have a very hard time pulling out the
The audio?
Yeah, the audio is not very clear. So if you would be able to repeat, that would be helpful.
Sorry, they were just asking about, right, the information regarding demographic information with the ER like data collection. And so we said that the age and gender, sex, or was it
Sex assigned at birth.
Sex assigned at birth were the only two things that are in the EMR, but there was, right, significant amount of missingness, no other factors, right? Looking at no Indigenous or other variables as part of demographics currently, right?
Yeah, that's correct. There are some patients who will choose to assign Indigenous or not, but it's by their choice. And I think that is a good question to ask. What questions should be asked at registration for patients coming into a facility? It may feel not very, culturally safe for them to acknowledge their ethnicity. They may, so I think to acknowledge that that's part of the systemic racism that we deal with within our system, but that is our reality. And I think that does pose challenges from that particular lens. I think an important lens that is captured is certainly the location as well, right? And we have that data, to be able to identify the equitable resourcing for or capture data from rural versus urban, which is often in research a disparity. So I think that's an important piece to highlight. And I think there may be opportunities within that to anonymously identify certain communities that might have higher ethnicity in their population. So there may be sort of an anonymous way to explore that further. So.
Yeah, and I do love that we really tried to represent, right, in the study, that really trying to hold true to the majority of it being rural hospitals that we tried to pull the information from to be consistent with the, right, kind of the geographic coverage of interior health, because we do know that that is not the same as, urban, more metropolitan. So I think that is something that I think will be a good future thing for us to be looking at, right? And how the populations in those areas, right, are disparate. Yeah.
I actually had a similar inquiry around like who are the people that you're talking about, for the people in the room, and I'm like, hear me, I'm Sarah, I'm associate now.
Congratulations.
Yes. In the schools, a lot of mental illness and substance use. And so just knowing that having a parent who's had a major event like suicide or a substance use like an overdose, and thinking about screening is one part, then what do we do with it? And considering that somebody is parenting, actively parenting, and has had one of these events, what are that the young person might go back home and say parents may rally around me, but as a parent I go back and I'm like, I'm gonna start making lunches again, I'm gonna start making breakfasts again, I'm gonna start doing all of these things again.
Christ. When they
Leslie, can you hear us? I think we lost. Nope, there we go. We lost him.
Sorry, fellow virtual attendees. Oh, looks like they might be back. I see Leslie and Aiden.
Yeah.
Okay, can you hear us now?
Yes,
Oh,
you're
there, now
back.
we can.
Okay,
Welcome
great,
back.
sorry. Yeah, so we had Sarah asked a question about kind of what happens to the adults, like to the parents of who are having these acute events after they've been discharged. And if anything, if our, research is going to speak to that after they're out of the hospital kind of concept. And so I was just sharing with her the work, Maria is familiar with it for the last 5 years that I've been advocating for publicly funded access to regulated mental health professionals, pairing with primary care teams, so that in either primary care or urgent primary care, that we would have access to those providers straight from actually hospital referrals straight into not just the physician, but the psychologist or that regulated mental health professional would have coordinated care with that person. And that's what I've been working on separately for the last 5 years. But that's obviously a larger initiative, but we see the suicide framework, right? Suicide prevention framework is a first really significant step as a part of creation of a system and coordination of care for these starting to decrease the gap. So I think we've been asking the providers and the patients. I think the patient survey and our chart data showed that less than 25% of patients received any follow-up contact or care based on what our current understanding is. But again, this is where you go out of one door into the community door. That's really a really, really big risk and gap. And that's really one of the things that I think we're hoping to partner with CMHA, right? And the authorities and the ministry is how do we help close those gaps. So it's straight from the hospital into the community with that may be augmented with audio, right? Automated support as a start, but then connected with the primary care team. But as we know that 80% of primary care, or 1 in 2 primary care visits are for mental and behavioral health already. And then you get the coordination of care coming from outpatient, inpatient, or the hospital.
Assuming they have family.
Yeah. One thing I might add is that Dr. Lutz has been really trying to integrate psychologists in primary care. So, we talk about the data of those that die by suicide who visit the ED, but we also have data on those that go to their primary care provider, don't get the help that they need, and then end up either dying or going to the ED. The ED, we've been in several talks recently. We had a great question, is the ED the best place to help these people, these patients? And the answer is likely no, if we can prevent people from even going to the ED. Right. So also seeing how this is all connected, and we're trying to address it at different stages, so that people don't, have to go to the ED and it doesn't get that bad. So we're definitely trying to be mindful of that too.
Yeah, there was a fantastic study in 2019 that was done where they showed from the coroner's office, they looked at records of people that had died by suicide in 2018, and they found that 75% of them had been to their primary care provider for mental health or substance use in the year prior. But primary care providers only have so many current resources, available. And we currently do not have publicly funded mental health in the province in coordination of that care. And so the truth and the reality is the majority of people are going to the ERs currently. So I want to deal with both where we're trying to get to and where we know other countries have been for decades, but also where we're at. So it has to be a simultaneous, coordinated effort to deal both with the acute care, and the management of that, making sure that it's evidence-based, it's effective, it's being done, it's acutely saving the lives, and then the coordination back into the community is one critical part. So with that, I want to turn it over. I'll put you in the spot here, Devin, for a second, just with Dr. Harris is now our new, what's the new official? Director of Health Systems, UBC Health. So I want to turn it over to Devin to make a few comments and as we wrap things up.
And I'm typing friendly thing. So you can summarize.
Okay.
Like I'm so comfortable with the material. Just to make it current invested to need that then you're the environment is that the 3 groups that come together in partnerships. So it's impactful work that the latter part that I said, and really the value of this as a forum is you can get people who have various interests, expertise, understanding, and partnerships with funding and others. You can actually do a lot of synergistically that you really wouldn't be able to do, which you guys clearly, and you clearly now have done. You'll clearly have legs in how things do. And I think all of us in various aspects can learn how to do this. And not have researchers separate from clinicians, separate from educators, separate from operational care delivery within the system. So it's inspiring, and I think the minister recognized that as well. So congratulations on that as well in the announcement, because it really impact. And being this is my home, and it's very proud to see it happen. So
Okay, yeah, I was gonna say that is, so Devin congratulated us for the minister's announcement in our work, and that also seeing how we're trying to really seamlessly partner together, right? The research not being siloed from the health authority, from, right, our community partners and agencies. So Devin, what else the other main points? Those are the two things I had. That was it, okay. So I know we have about 5 minutes left. I just wanted to maybe come back and close with each of you, kind of your closing thoughts. Start with you, Maria, kind of about, you know, everything and culminating. It was quite a busy last 72 hours with the minister being able to formally announce and support and endorse this framework. So, you know, congratulations to CMHA for the years of work, but would like to turn it over to you for a minute first.
Thank you. Yeah, I just wanted to echo what's already been said, that this has been such a great partnership, and I've linked as well. I know the folks in the real world room can't see it, but there is a news release that's just gone out on the BC government website where you can actually access a copy of the framework. And by all means, like, feel free to reach out. Like we said, this is one of 5 projects taking place. They all look slightly different, but there's some really great work. Some of it is with I know the kind of parenting piece was about parents as a client or patient, but there's work being done with parents and caregivers of people who are caring for people with thoughts of suicide. So I'm just really thrilled to see so much work being done in this area, because it has been a historically very kind of underserviced area of work. So just really thankful for everyone that's contributed to this and really brought kind of light to and hope to an area that I think has been kind of left in the dark for a long time. So yeah, thank you.
Thanks, Maria. Amy, over to you.
Yeah, I also would like to echo what everyone else has said. I'm just very grateful to be a part of this partnership, and feel grateful that we can hopefully provide better care for these patients and mental health patients in our regions. And the other cool thing is I'm having people all over the province reaching out to me about some of this work, as well as people across provinces kind of asking what we're doing and how we can support mental health patients in our communities and our emergency departments. So grateful to be a part of this work. Thank you.
Thanks, Amy. And Aaron?
Yep. Thank you, everyone, for taking the time to listen to us and to hear about this work. And I think the key thing to pass along, as Devin, I think I've mentioned as well, the opportunity for collaboration is the key, and it's within multiple partners, and really trying to be open-minded about who they are and really bring them to the table collectively for the common good. As Leslie mentioned, we all continued on with that common vision of bringing the best quality care we could to patients on the front line, and I think that is the opportunity. So please, in those in the audience or listening to this, reach out to clinical networks with expertise in the area that you are focused on, and look for opportunities to collaborate. We're keen and really excited to be a part of this work together with you guys. So thank you.
Fantastic, and thank you. I also want to turn to Aidan, who has been working on this now. That was his very first thing on day 1 of grad school. I said, I want you to work on this project with us and head it up. So Aidan, what do you have for your reflections today?
Yeah, I think closing remarks would be, I do a lot of the behind the scenes data collection and really hearing patient stories. And I've just been so amazed at the problem solving nature of everyone I've worked with. We've had hurdles. It's not, nice and neat laboratory research. These are real people that we're impacting, and I've just been really grateful for all of the help and support, because you know, things happen, and we've been able to overcome those and accomplish all that we have. So speaking to that collaboration as well.
Perfect. And I want to give a shout out that that Aidan will be defending his master's thesis on a component of this project in the next 30 days. So he is now knee deep in writing for finishing. But I would like to just close with today. I think it's really a historic day for many reasons. One, here, this is the first time we've had a UBC Health conference on this campus, as well as the Vancouver campus. I think this has been a long time coming. I'm really, really thrilled to see that. I feel only hope and excitement about the synergies and the commitment and understanding of excellence on both campuses that can be brought to helping solve the most urgent issues of our time. And I particularly want to, say such a note of gratitude to Minister Osborne. I've had the pleasure of meeting with her a few times now already. Her commitment to mental and behavioral health and system transformation is like something I've never seen. She understands the science, respects it immensely, and wants to use it in real time to make meaningful differences. So, and I feel this goes all the way up to, my meetings with the Premier. He is absolutely laser focused on mental and behavioral health and system transformation as well. And so today's announcement really for me is the beginning of these larger and more significant transformations with regards to close the gaps in care, to not just save lives in the acute moment, is to save, money, of course, but time and burnout of our healthcare providers, improve efficiencies, coordination, improve quality of life for family members that are living with those, never mind the individuals themselves. So I see today as really a historic day, and first really significant step as we move forward. And partnership is absolutely the theme. And again, if it wasn't for IH coming to me 3 years ago saying, do you want to partner? I was like, I'm not sure I'm the right person. I don't know if we have enough time. The answer, I'm so grateful that this happened. And we feel like this is now a long-standing partnership and we can't wait to keep going. So thank you to everybody. With that, we will close out today's session, and thanks again.